Good morning to one and all. Myself, Ashwini Ashokan, dermatology resident from Amrita Institute of Medical Sciences, Kochi, on behalf of IADVL Kerala, would like to extend a warm welcome to each one gathered here with us today for the online CME for platelet-rich plasma therapy. We shall start today's session with the welcome speech, for which I invite Dr. Vinita Varghese Panikar, Chairperson, Online Academy Cell. Over to you, ma'am.
Thank you, Ashwini. On behalf of IADVL Kerala and Online Academic Cell, it's my proud privilege to welcome you all to the next of our CME series. Today's topic is on platelet-rich plasma. As you all know, regenerative medicine is the most upcoming specialty in all fields of medicine, and of course, we dermatologists have also agreed to do in that field. So we thought that it's very relevant to have a session on this. Today, to discuss the same, we have an eminent panel of experts who are Dr. Sonia Feroz. She's a director and consultant at Serene Derma Trivandrum. We have Dr. David Pudukadan, who's a professor of dermatology at Jubilee Mission Thrissur. Dr. Rakhi Nair, my dear friend, she is Associate Professor of Dermatology at Assisia Institute of Medical Sciences. And we have Dr. Naveen Thomas, Consultant Dermatologist at Medical Trust Hospital, Cochin. I welcome you all. Thank you for consenting to be with us here. And I know we will have a lot to learn from their enriched experience. I also welcome our dear President, Dr. Faisal sir, who has consented to be here with us and inaugurate our session. And once again, I welcome you all delegates to this session, and I hope you will have a very fruitful session today. Thank you.
Thank you, ma'am. I welcome Dr. M.M. Faisal sir, President IADVL Kerala, for the inauguration speech for the event. Over to you, sir.
A very good morning to all of you. It is my pleasure to inaugurate this online CME organized by EC and Online Academic Cell of IADVL Kerala. Today's topic is platelet-rich plasma. Platelet-rich PRP is a biological product that is a portion of plasma fractions of autologous blood with platelet concentration above the baseline. PRP is a new therapeutic option currently used in different medical fields. In the interest in application in dermatology has recently increased. It is being used in several different applications, as in trichology, cosmetology, wound healing, etc. Today, we have eminent speakers here to discuss about PRP. I am grateful for the support and hard work of all the members of Online Academic Cell and the Executive Committee. I extend my heartfelt gratitude to the faculty of today's program, Dr. Sonia Feroz, Dr. David Pudukadan, Dr. Rakhi Nair, and Dr. Naveen Thomas. I wish all the success for this CME. Thank you.
Thank you, sir. Now we shall be commencing with the CME. And for the first session, we have Dr. Sonia Feroz, Director and Consultant, Dermatologist, Serene Derma Trivandrum. who's going to address us about the evidence-based approach on platelet-rich plasma therapy. Over to you, ma'am.
Hello, good morning, everyone. Hope I am audible.
Yes,
Yes,
you're
ma'am.
audible.
Yes. Thank you so much for having me here. I extend my gratitude towards Dr. Vinita and Dr. Joanne, who had actually invited me for this. And thank you, Dr. Faisal, for that introduction and the inauguration. So today, I'm here in search of evidences in PRP treatment. Let me share my screen. In this session, I'll be joined by two other eminent speakers, Dr. Rakhi Vinayar and Dr. David Pudukardan, to extend their experiences and new evidences which they can contribute. Together, let us find out the answers to our own questions and doubts regarding PRPs. So, why do we do certain things that we are doing? This is a general life question. Because we love doing certain things, or we would love to explore new things in our lives, right? So when we think about anything in our own dermatology specialty or practice, when we try to do something new, we have to understand what is the basic science behind it, what are the areas in which a particular treatment can be used, the updates regarding whether the peer group experiences or published articles, we have to find it out and implement in our own practice and get our own vision. That is more important than anything else. So my agenda for today, about 10 to 11 or 12 minutes, I'll introduce this method of PRP. I'll give some idea about the terminologies, and I look up certain articles on these and ask certain self-doubt questions which may be answered in the next presentations. If not, we'll discuss in the last 10 minutes of discussion, panel discussion. So it's good to know where we came from, right? This therapy, the PRP therapy, originated from transphysiology in early 20th century. When it was applied as a concentrate of platelets, just give me a moment, platelets to treat thrombocytopenia. So during the 1960s, the first blood bank preparation appeared and became popular in the 1970s. So the PRP treatment is as old as 70 years and has an increasing number of applications nowadays. The hypothesis of the growth factors inside the PRPs was established between 1960 and 1989. So after that, the importance of growth factors inside the PRPs were determined. And then after that, there was a rapid increase in the development of techniques and indications, whether in skin ulcers, reconstructive surgery, in tendons, ligaments, muscles, cartilage, etc. And gynecology, urology, and ophthalmology. In early 2010, the PRP gained popularity in cosmetic dermatology. But when I was searching for those evidences, the extensive reports before this period, like before 2010, we could see a lot of reports, but they were all in other specialties, like in the oral maxillofacial surgery, implant dentistry, blood transfusions, then again, in plastic reconstructive surgery, spine journals, etc. Most of them were like that. So in 2014, Dr. Rachita Durat and Dr. Sukesh had come up with a very good review article stating all the principles and methods of preparations of platelet-rich plasma, a review and author's perspective. In this article, they reviewed the principles and preparation methods and placed their perspective in standardizing a safe, simple protocol that can be followed to obtain an optimal, consistent platelet yield. This article was one of the backbones where everybody used to refer during that period. Still recently, when the recent consensus have come regarding the use of PRP. So, what is the definition of PRP? The marks propose that platelet count of 10 lakhs per ml in 5 ml of PRP. That means 1 million per ml in 5 ml of PRP as a working definition of PRP based on the scientific proof of bone and soft tissue healing enhancement. But there was scarcity of studies stating the concentration at which the optimal stimulation occurs. So in certain studies, it was found that the stimulation of proliferation of endothelial cells peak at 1.25 and angiogenesis at 1.5, 10 to 10 raised to 6 platelets per ml respectively. So that shows why certain things will not work and why certain studies were working, because of the defective platelet concentrations. In 2009, Renfest et al. Divided this PRP into 4 different families according to cell content and fibrin architecture. It was pure PRP or the leukocyte poor PRP, where when there were no WBCs, plus they have the low density fibrin network. The LPRP is with WBC and low density fibrin network, and PPRF without the WBC plus a high density fibrin network, which was a little bit thicker, and LPRF, again, the second generation PRP products with the WBC and the high density fibrin. So most of the commercially available kits come in the LPRP section. So why do we need platelets at all? They contain various growth factors and cell adhesion proteins like fibrin, fibronectin, and vitronectin. And these are stored where? In the alpha granules mostly. Alpha, delta, and lambda, or the lysosomal granules, are there. But the alpha granules are the most abundant ones, and that is where almost every growth factors pertaining for us are concentrated. In the alpha granule, there are a lot of growth factors, but I've just chosen the most important ones. They are the platelet-derived growth factor, the transforming growth factor, the EGF, and the VEGF. All these 4 are the most important ones when the skin and hair is concerned. The insulin-like growth factor and the other growth factors are mostly into those osteoblasts and fibroblast proliferation and mechanisms. This is an activated platelet which releases all the granules, and they have activities over those immunomodulation, angiogenesis, proliferation, chemotaxis, anti-fibrotic effect, anti-apoptotic effect, and all those stem cell supports. What are the hurdles? We need quantity and we need quality also, because damaged platelets will not secrete bioactive growth factors. So we need quantity and quality. And how exactly and how many platelets will be activated to release growth factors is not known. It's very subjective. And the presence of RBCs and WBCs may or may not interfere with the growth factor action. Let's see how things are going. And the therapy gap between whether the preparation to injection or the gap between the injections are also not determined properly. And the variable loss of platelets can happen, therefore variable concentration in each sample. Within the patient, within the next sessions, or in between patients also, there'll be a lot of differences in their own patient platelet concentrations. So is leukocyte and erythrocyte actually needed in the preparation? If this thing contains RBCs, the pro-inflammatory cytokines within the erythrocytes can lead to a formation of free radicals, which may damage the tissue being treated. So definitely we don't need RBCs. WBCs, yes, the proteases can cause a negative effect in the whole scenario, but the leukocytes are supposed to be protective for the platelets and for the growth factors to act. So the techniques and the mechanisms will be discussed in detail by the next presentators. There are different techniques of separations, like you have the normal blood vials where it is taken up with the anticoagulants and centrifuged. You have those narrow neck tubes, which are quite popular in the commercially available kits. And then the most popular ones are vacutainers with thick strophic gel in between. And there are umpteen number of other preparations. Is exogenous activation necessary? That's another question, because there are preparations where there is added calcium chloride before injecting onto the target area. But the controversies are there, because there is a risk of premature degradation by proteases of the extracellular matrix. And the growth factors which are released prematurely only have a short lifespan for a few hours. So there is limited number of receptors for them to bind to. So that also is not favorable. that the platelets are inactive, they protect and release them gradually over a longer period of time. And there is long-lasting and more significant successes. So there are people for and against the PRP activation exogenously. Now, I have gone through a lot of studies from which I could just gather a few regarding the PRP in androgenetic alopecia. The effect of PRP on the yield of follicular units in male baldness surgery was observed for the first time by Ubel et al. In 2006. The growth factors bind to the tyrosine kinase receptors on dermal papilla cells to activate MAPK-ERK pathway, leading to proliferation, differentiation, and cellular survival. At the same time, these can result in an anti-apoptotic effect. So definitely that is pro-follicular units. So the vascular endothelial growth factor and the EGF, hepatocyte growth factor, fibroblast growth factor, and IGF-1 have angiogenic potential and can increase vascular structures around the hair follicles. And there is an interesting article published in 2019. They reviewed almost 19 articles, and they published by Hessler et al. Concluded that PRP is beneficial for hair growth. So now we cannot say that there are no evidences. There are evidences for PRPs which are beneficial in hair growth. This is just one picture of one of my patients with after 4 PRP injections. Irrespective of whether PRP is administered alone or in combination with other agents, it seems to be a promising treatment for AGA. But there was other studies too. 2 RCTs in 2016 conducted by Mapper and Pugh showed no positive effect of PRP on AGA. And studying this publication, the possible causes for the unfavorable results can be one, the advanced stages of AGA where they have tried, and the low number of PRP injections. That 1 injection in Pugh and 2 injection in Maper et al. It has to be multiple injections, and injections were too deep. So the subcutaneous in Pugh and the deep dermis in Maper et al. And use of a subjective evaluation method only, whereas other studies used a folliscope as an objective evaluation method. So there are a lot of variations in the outcome of or the response. There are umpteen number of other uses of PRP. Skin rejuvenation is the most common one, where they're used in skin aging, and the periorbital rejuvenation. The PRP has been used clinically for skin rejuvenation for several years without any studies saying whether, yes, it was good or bad. And the first randomized controlled clinical trial was conducted in 2018 by Alam et al. And where they injected PRP and saline in one cheek and the contralateral cheek. And they could significantly identify the improvement in the skin elasticity and skin firmness. But the assessment of skin improvement is really challenging. They had used cutometers and 3D scans, but they should be standardized photography. 3D scans, which are limited due to high cost, so everyone can't use that. We can just be happy with skin and hair analyzers. Other uses are melasma. There was an interesting journal in 2014 where they showed the regression of melasma with platelet-rich plasma treatment, because melasma is considered as a global aging condition. And in psoriasis, there was a published paper in 2016 where the clinical efficacy of platelet-rich plasma in combination with methotrexate in chronic plaque psoriasis was attempted. Nail disorders, in 2019, there's a publication where there is intramatricial platelet-rich plasma therapy. They came up with this as a novel treatment modality in refractory nail disorders. So there is something for us to try now. In vitiligo, yes, PRP to suspend a non-cultured epidermal cell suspension, and that showed to improve the repigmentation after autologous transplantation in stable vitiligo. That wasn't a study in 2019. And even in cicatricial alopecia, there was a study in 2019 commentary on the use of PRP in cicatricial alopecia and PRP in chronic alopecia. In both, they have come up that it is better than the usage of multiple steroid injections. So there are a lot of basic science questions, again, keeping coming up in our minds, like can needle size affect the PRP rupture, platelet rupture? Topical anesthetic, should it interfere with platelet function, or temperature of centrifuge matters? the blood test before PRP? Should we do and see the blood count before we do the PRP? Or can we take the convalescent serum? Is there any problem with that? The questions, I know everybody has got a lot of questions in their minds. To conclude, with the unveiling of its mechanisms and clinical efficacy in recent years, PRP seems to be a very promising therapeutic modality in the field of dermatology. PRP used alone or in combination with other therapies showed beneficial effects in terms of cosmetic improvements and for some skin diseases. So thank you so much. And with that, we will move on to the next speaker. Thank you.
Thank you, ma'am. For the next session on the aesthetic indications of PRP, I invite Dr. David Pudugatan, sir, Professor, Department of Dermatology, Jubilee Mission Medical College, Thrissur. Over to you, sir.
Good morning, all. Thank you, Irene, Carrie, and Vinita for inviting me for the session. I'll just mention about the use of platelet-rich plasma in rejuvenation. I have to say that I use a pre-prepared kit when I'm doing PRP. I don't use the other. I always use that. I had limited experience with the other kits, or the way open method and all those methods. So as a treatment modality, it has become very popular these days, and it's a logical choice for replacing a renewing cell. 1 second. Has become the logical choice for replacing and renewing cells, tissues, and organs because of the low invasiveness, high healing, easy availability, and abundant growth factors. When you inject a PRP, the platelet releases a lot of proteins, including the PDGF, VEGF, transforming growth factor beta, IGF, etc. And we have used PRP as a monotherapy or in combination with other modalities like fraction CO2 and resurfacing modalities for skin rejuvenation, acne scar, periorbital rejuvenation, lipofilling, etc. Now, the proteins and the growth factors released can stimulate the stem cells, improve cellular proliferation, differentiation, regeneration, leading to skin rejuvenation. It stimulates the fibroblasts to release hyaluronic acid, which hydrates and improves the volume of the tissue because of the hygroscopic effect. Then there is increased expression of MMP 1 and 3, resulting in removal of photodynamic extracellular matrix. Then PRP can activate fibroblasts, increase collagen secretion, and extracellular matrix elements. These provide tightening and scar attenuation. It has also been used in cancer healing, wound healing, with the increased expression of the G1 cell cycle regulator. Now, what you can see when you inject a PRP is a statistically significant increase in the epidermal and dermal thickness. And then there is an increase in the amount of collagen fibers and organization of the collagen fibers, and significantly reduced solar elastosis or the tissue destruction. Now, to conclude, when you are using PRP in skin rejuvenation, PRP stimulates the removal of photodamage extracellular matrix, induces the synthesis of collagen, stimulates the synthesis of body's hyaluronic acid, thus increasing the dermal elasticity, and it has a volume effect. Now, it has also been used in periorbital rejuvenation. The current quality of evidence is 1B, the standard for recommendation is 2A. So when you get a wrinkling around the eye, it may be the first sign of aging, and it can cause immense psychological distress. PRP, because of its release of TGF beta, can reduce the pigmentation, in addition to the other effects on the collagen and the release of hyaluronic acid. So, so it has an effect on pigmentation, it has an effect on tightening, it has an effect on volume and hydration, etc. Theoretically, PRP can have a similar effect as hyaluronic acid fillers, with an added effect on the pigmentation aspect. Now, what are the indications when you're using PRP for skin rejuvenation around the eye? You use it for loss of volume, you use it for the wrinkles, dark circles, erythema, loss of elasticity, and cirrhosis. The points to note when you're injecting PRP around the eye is that the area is prone to bruise. So You have to tell the patient that you can have some amount of ecchymosis around the eye after the PRP injection. And then there are a few reported cases of blindness after injecting around the eye. So this has entered into the vasculature and has caused blindness. So again, that is something which you have to keep in mind when you're using around the eyes. Best results are seen in younger individuals, and the usual schedule is once a month injection for 3 sessions. So as I said earlier, it can cause filling of the volume defect, it can correct the wrinkles, it can cause thickening of the epidermis, and it can improve the pigmentation. Now, these are the studies, one by Kang et al. On 20 Korean females, which showed a decrease in the erythema index and melanin index. And then there is a study from Jordan on which showed again a significant improvement in the dark circle. Now, this is a meta-analysis of treatment of the periorbital region with the platelet plasma by Evans et al. And again, this showed great patient satisfaction, improvement in the color and texture, and compared to saline platelet poor plasma mesotherapy, and even used as an adjunct to laser therapy. Now, hand rejuvenation is another area where after treating the face, patient always asks for the hand. So again, there is photo damage to the skin, there is wrinkling, there is pigmentation. This has to be corrected. All these points are tackled when you are injecting PRP. So it can correct the photo damage extracellular matrix, and it can improve the synthesis of collagen. It can reduce the pigmentation and reduce the liver spot. So there is overall improvement in the skin texture of the dosing of the hand. Melasma, there are very few studies available. It's mostly used as an adjunct therapy when you are giving. So mostly you would have given hydroquinone, you would have given calisthenic acid, you would have given sunscreen, you would have given some peels and lasers. And if all these things fail, or as an adjunct to all these therapies, you can inject PRP into the lesion. And there are various studies on that. Hoffney et al. On 23 adult Egyptian melasma patients, he treated the melasma with PRP, which showed very good improvement. Another study by Siritana Bedikul et al. On 10 female mixed fiber melasma patients also showed a very good improvement. But there is paucity of studies, and more studies are required to say that it is a part of the treatment protocol for melasma. So from these two studies, there was significant improvement in the PRP treated side of melasma. Coming to PRP in acne scarring, though it is not part of a rejuvenation, Redeli et al., when he was injecting a patient with PRP for rejuvenation, observed that there is improvement in the acne scar. And this was reported, and that led to the use of PRP in treatment of acne scar. L-PRP is preferred because leukocyte releases VEGF, which leads to angiogenesis, and that has a beneficial role in acne scarring. And it can be used alone or in combination with conventional treatment to increase the efficacy of these treatments. So usually what we do is we combine it with fractional CO2 laser or RF microneedling, and PRP is seen to improve and accelerate the post-acne treatment recovery. It can be used as a monotherapy. When used as a monotherapy, it releases the growth factor. It can lead to extracellular matrix regeneration. Then there is increase in collagen, increase in linoleic acid. And histology also has revealed there is increase in the collagen bundle formation and increase in the thickness of epidermal layer. But there is a randomized study by Tuja et al. Comparing CO2 laser microneedling monotherapy with PRP monotherapy, found it very inferior to CO2 and microneedling. So the strength of evidence is not that high as a monotherapy. It can be combined with other treatment to improve the efficacy of other treatment. Now coming to PRP with microneedling, you can use it as a topical agent or as an intradermal PRP with variable result. It has synergistic effect. Both leads to release of growth factors. There is wound healing cascade, and then there is improvement in the scar. Now, as a monotherapy, sorry, just 1 second. Comparing topical PRP with intradermal PRP with microneedling, both lead to decreased healing time, which is observed in majority of the study. Chawla and Naufel et al. Have confirmed the improvement of atrophic acne scar when they are combined with microneedling or or used as intradermal injection. But a statistically significant difference in result was not seen when used as a topical PRP. And this may be because the interstitial fluid and fibrin will fill up immediately after the needle has passed through, and this limits the uptake of PRP. So we can enhance the penetration of PRP by applying an occlusive dressing like a cling film on top of it. But again, the recommendation is less when you're using topical PRP with microneedling. Intradermal PRP with microneedling, there is greater patient satisfaction. The majority of patients reported that PRP led to reduction in the visibility of acne scar and improvement in the skin texture. Corval et al. Compared a dermaroller on one side and intradermal injection of PRP with dermaroller on the other side, which showed a better response than the intradermal injection of PRP. We must highlight again that the topical PRP has limited efficacy, hence intradermal PRP is better when combined with microneedling. So combination with microneedling, better cosmetic outcome, there is higher patient satisfaction. Intradermal PRP should be the preferred mode of PRP delivery. Now, these are the results. The top ones are the treated site, which showed a better response when given intradermally with microneedling. So, and there are a lot of studies on that, combining microneedling treatment with PRP, combining microneedling treatment with PRP for acne scar. And all of them have shown better response when there is a combination of both. Now, combining it with fractional CO2, strength of evidence is 1B quality of evidence and 1/2A strength of recommendation. There is a beneficial effect when combining PRP with ablative lasers like fractional CO2. Combination of topical or intradermal PRP with laser has been shown to decrease the erythema, swelling, pain, though significant improvement in the final results are not seen. So that means that final result is the same. You're just doing laser alone. You are doing topical PRP with laser, intradermal PRP with laser. The final result is the same, but the patient satisfaction is more. There is decreased swelling and erythema and pain. So the symptoms or post laser side effects are much less when you are combining it with PRP. Now, there are a lot of studies recommending use of PRP in with laser for acne scar, and now this is a improvement. PRP plays a role in the remodeling of the extracellular matrix. There is increased expression of matrix metalloproteinases, which stimulates the remodeling process. Now, what effects you can get is it decreases the downtime, leads to faster recovery of transepidermal water loss, better cosmetic results, better histological outcome, and higher patient satisfaction. So this is a good combination, PRP and fractional CO2. Now, when you are filling a defect on the face with the autologous fat, it is seen that you have to inject 30%, an average of 30% extra to get the desired effect, because there is ischemia of the adipose tissue after injection, and there is apoptosis because of the handling. So when you add PRP to this autologous fat, there is a pro-angiogenic effect, which increases the vascularity of this fat and then helps in fat graft retention. And so it's a combination of autologous fat with PRP is recommended. Now, with for stretch marks, a combination of PRP and MNRF shows much more beneficial results. I haven't compared. I have done for many patients PRP with MNRF, but I have never compared one side and untreated side and the other side. So the results are good. Around 6 to 7 sessions are required to get a very good result. Now, even though it is not part of rejuvenation, it can be used in skin ulcers because there is release of growth factors like PDGF, VEGF, EGF, IGF, IL-1. There is cell proliferation and angiogenesis. There is decreased inflammatory cytokine release. There is antimicrobial effects. Then these granules are known to attract macrophages, and there is accelerated reepithelialization process. So all these help in skin ulcers. The antimicrobial effect is by the antimicrobial protein secreted by the platelets. Plus, in an LPRP, the leukocytes help in combating the infection and regulates the immune function. Now, the evidence in treatment of ulcers, chronic ulcers, venous ulcers, neuropathic ulcers, and diabetic ulcers have good evidence. Scleroderma and acute ulcers have limited evidence. Now, we can use whatever is left behind, that is a platelet poor plasma after preparing a PRP. The plasma is coagulated by keeping in 80 to 90 degrees centigrade water bath, and that is used as a filler. So this is used in correcting the volume loss on the face, especially over the periorbital area. And it has been used in punched out scars like post-varicella scars, which respond poorly to sufficient. Dashori and Dashori has shown that the biofiller volume reduction starts at 1 month, and you have to actually refill at 3 months. But some effects remain still 6 months. And as I said earlier, it is that's used for tear trough reduction and hyperpigmentation reduction, and it is better than the PRP alone. When comparing it with dermal fillers, the longevity is less. So dermal filler gives around 1 year or 1.5 years depending on what filler you are using. But this is a very cheap product. This is a byproduct when you are making a PRP. Now, I'm ending with the consensus. PRP is the preferred type of PRP for facial rejuvenation, while LPRP is preferred for acne scar and ulcers. Young patients are the ideal candidates because they respond best to PRP treatment. And it shows an improvement in all acne scars, especially the rolling scar compared to buff scar and ice pick scar. Severe atrophic scar can be combined with other modalities like needling, suction, CO2 laser, etc. Combining PRP with CO2 laser and MNRF is desirable because it significantly reduces the healing time, decreases PIH, and increases the patient satisfaction. It is a good modality for the periorbital area. Biofiller can be used again in the periorbital area. Intradermal is the recommended modality nowadays for all indications of PRP. Then 3 to 6 sessions are recommended. The results are expected only after 4 to 6 weeks of treatment. You can use topical nerve blocks, eyes, vibrators, etc. to reduce the pain. And safety is established, longevity is questionable. So thank you for patient listening.
Thank you, sir. For the next session on trichology, I welcome Dr. Raki Nair, Associate Professor, Department of Dermatology, Azizia Institute of Medical Sciences and Research. Over to you, ma'am.
Thank you, Dr. Ashwini. I'll just share my screen.
Yes.
I think Dr. David has to exit. Is my screen visible?
Yes, ma'am.
Yeah, okay. Okay, good morning to all of you. And let me at the outset thank IADVL Kerala as well as my dear friends Dr. Vinita and Dr. Joanne for inviting me for this talk. So PRP, whether it's a boon or bane. So it has been a discussion since long, and at present we have got some consensus about it because the IADVL National Academy had come out with a consensus statement with a task force for PRP. So I'll be dealing with the trichological aspects, like it has been already discussed by the previous speakers. It has got angiogenic, mitogenic, and chemotactic effects due to its varied growth factors. Now, what is the rationale for use of PRP in hair growth? The dermal papillae cells, they produce growth factors such as IGF-1, FGF-1, FGF7, and hepatocyte growth factor and VEGF. Now, these growth factors are responsible for maintaining the hair follicle in the anagen phase of the hair cycle. Hence, the potential target are the DP cells. So upregulating the growth factors within the DP cells will lengthen the anagen phase of the hair cycle. Then the epidermal growth factor and the transforming growth factor are involved in regulating the growth and differentiation of the bulge cells. So that is again another potential site. Then platelet-derived growth factors, they have a role in the interaction between the bulge and the associated tissues, starting with follicle morphogenesis. Now, mechanism of action of PRP in hair, there is upregulation of transcriptional activity of beta-catenin, differentiation of the stem cells into hair follicle cells, increase BCL2 anti-apoptotic. Therefore, it again prolongs the survival of dermal papillae cells. Then expression of the activation of AKT-ERK, then FGF7 in dermal papillae cells prolongs the anagen phase of hair cycle. There is increased VEGF and PDGF, which are pro-angiogenic, thereby increasing the perifollicular and the vascular plexus. Now, why PRP is, what are the indications of PRP in our trichology? There are both non-cicatricial alopecia cases which are targeted with PRP as well as cicatricial alopecia. But cicatricial alopecia, we have more of anecdotal studies. So in non-cicatricial alopecia, we have androgenetic alopecia, female pattern hair loss, alopecia areata, chronic telogen effluvia. And cicatricial alopecia, the commonest ones are lichen planopilaris, central centrifugal cicatricial alopecia, and frontal fibrosing alopecia. Now, studies in trichology are umpteen, like even Dr. Sonia showed, there are umpteen studies. But however, and 74% of the studies show improvement from baseline. However, there is heterogeneity in measurement variables. Then the preparation methods are not standardized. There are different types of preparations, different types of tubes, double spin, single spin. So outcome variables are also not adequate. Most of them are qualitative analysis rather than quantitative analysis. Hence, it's difficult to conclude. However, 34 RCTs show that PRP is better than placebo and it can be used as an excellent adjuvant. Inconsistent measurements and variable protocols limit the comparison, and that is where we need to be more adept at studies. So coming to some of the good studies, this is a randomized placebo-controlled double-blind half-head study to assess the efficacy of platelet-rich plasma on the treatment of androgenetic alopecia. It was done by Alves and Grimal. 25 patients were recruited, and PRP versus placebo, that is normal saline, was used. It was a split scalp study. Photography and trichoscan were used to assess the improvement. 5 ml of PRP was given on the right side, and monthly sessions, 6 such sessions were given as monotherapy. Now, these were the results. On global photography, we can see the improvement. Even photo trichoscan showed an improvement. Now, on the right side, we can see that improvement in hair density, it was statistically significant with the PRP group. There was another study by Cervelli et al. It was a band-like controlled split scalp study. Normal saline injections were compared with monotherapy of PRP, photos, trichoscan, and in this, histopathology was also done. 10 subjects were recruited, previously treated with a wash-off period or naive, and 6 monthly sessions of PRP monotherapy was given and 6 months follow-up. Here again, we can see improvement both in the frontal, in the crown region as well as vertex region. And this is again the trichoscan which showed an improvement. Now, histopathological examination also showed that there was improvement in epidermal thickness. There was improvement in the number of follicles. Ki-67 staining, which is a stain used for keratinocytes, both in the epidermis as well as in the follicles, showed improvement. CD31, which is a marker for blood vessels, showed improved angiogenesis. Now, PRP and grades of androgenetic alopecia, the studies showed that it worked better from grade 2 to grade 5 and in Ludwig 1 to 3. Now, platelet-rich plasma for androgenetic alopecia, there was another pilot study by Sean et al. 42 men and 22 women, treatment naive in Norwood Hamilton scale 2 to 5 and Ludwig 1 and 2. PRP monotherapy was tried, 6 sessions monthly were given, and 5 to 5.2 ml was given total. Photography and a questionnaire for patient satisfaction was used. It again showed improvement in both females as well as in males. Now, combination therapy studies, platelet-rich plasma in combination with 5% minoxidil topical solution and 1 milligram oral finasteride for the treatment of androgenetic alopecia, a randomized placebo-controlled double-blind half-head study done by Alvis and Grimald. There were 24 patients. There were 4 treatment arms. Oral finasteride 1 milligram plus PRP, oral finasteride 1 milligram plus normal saline. Then the other arms were topical minoxidil 5% plus PRP and topical minoxidil plus normal saline. Now, in the results, we can see that in the hair density, minoxidil 5% plus PRP showed a definite improvement as compared to finasteride with PRP. And even anagen-telogen ratio percentage also showed that combination of minoxidil with PRP was better. Now, in alopecia areata, randomized double-blind placebo and active control half-head study was done to evaluate the effect of PRP on alopecia. It was String who first did the study in alopecia, and 45 patients were taken, split scalp, intralesional steroid versus PRP. 3 sessions were given 1 month apart, and efficacy variables were macrophotography, dermoscopy, and cell proliferation, that is Ki-67. So SALT score improvement, reduction of dystrophic hair, increased Ki-67 tagging, and there were no relapses at 9 months of follow-up. On the right side, we can see the PRP untreated side and the PRP treated side. Again, recalcitrant alopecia areata, 20 patients, biopsy-proven cases, recalcitrant, that is 2 years of various treatments were tried. 6 sessions of PRP monotherapy was given and follow-up was done at monthly, 6 months and 1 year. Outcome measurement was global photography and PRP was given at monthly intervals. The photography showed good improvement. It has also been tried in recalcitrant ophiasis type of alopecia areata. It's a case report. 3 injections monotherapy was given at monthly intervals and outcome measurement by photography showed good improvement. Now, in chronic telogen effluvium, there are very few studies, and this was a study done by Raham and Abel Halim in Egypt, and the evaluation of safety and efficacy of PRP in the treatment of female patients with chronic telogen effluvium. It was a randomized controlled double-blind pilot clinical trial. Females 18 to 55 years were recruited. Chronic telogen effluvium without any underlying cause, and who were not responding to any of the other treatments. 4 sessions of PRP versus placebo, that was normal saline, was tried. Monthly sessions were given. Follow-up at 1 month and 3 months. It showed good improvement. The left side was the PRP treated cases and the right side was the placebo. Now, in cicatricial alopecia, we have only anecdotal reports. However, when there is limited tools in our armamentarium, we can always try PRP. Lichen planopilaris, centrifugal cicatricial alopecia, frontal fibrosing alopecia. So the probable mechanism of action may be the reversal of ischemia or the action on the vascular bed insufficiency caused by the release of the growth factors. So these studies showed that there was positive response with PRP and there were no complications. So this is a 70-year-old female biopsy-proven lichen planopilaris. She was on topical calcipotriol and HCQs. It was unresponsive. The orals and topicals were continued and PRP was given for 3 sessions monthly, and at 6 months follow-up, she showed good improvement. Again, 53-year-old female, biopsy-proven case of central cicatricial alopecia, central centrifugal cicatricial alopecia, intralesional triamcinolone, spironolactone, and minoxidil 5% was given, unresponsive. All the treatments were halted, and PRP monthly sessions were given for 3 sessions, and there was more than 50% regrowth. Frontal fibrosing alopecia, again, 54-year-old female, she was diagnosed as frontal fibrosing alopecia. We can see the dermoscopy changes also. Treatment was taken, was HCQs, ILS was given 3 sessions, topical steroids, all for 5 months, but unresponsive. PRP 3 sessions were given monthly. Photography and dermoscopy showed improvement. Now, PRP has been used in hair transplant. It is used, it's added to the storage solution. It's used for bathing the follicles in PRP before implantation, injecting PRP immediately after surgery, and PRP in the donor area. Now, recent studies have suggested that statistically significant improvements in hair density and stimulation of hair growth occur when the follicular units are pre-treated with platelet plasma growth factors before implantation. In a single-blind prospective randomized study on 40 follicular unit extraction hair transplant subjects, PRP was injected intraoperatively immediately after creating slits over the recipient area in the PRP group and normal saline in the non-PRP group. And all subjects who received PRP had more than 75% hair regrowth at 6 months, whereas in the non-PRP group, only 4 patients had more than 75% hair growth at 6 months. And the number of patients having lengthier hair was significantly more in PRP group. Now, this is the pre and post pictures of the PRP therapy with FUA. Now, PRP and monofilament PDO threads, these are being used in many places. The mechanism of action may be the neocollagenesis via sustained foreign body reaction and in the improvement in the microcirculation. And there is a natural bioscaffold for the autologous growth factors in PRP to act. So it's a sustained release growth factor model. And the advantage of using this is that we can reduce the frequency of PRP administration to once in 6 months. Now, the IADVL PRP task force consensus statement came out in 2021. I was also part of it. A comprehensive literature search was done in English language on the PRP across multiple databases. The grade of evidence and strength of recommendation were evaluated on grade framework. A draft of clinical recommendations was developed on the best available evidence, which was also scrutinized and critically evaluated by the IADVL Academy of Dermatology. Based on the inputs received, the final consensus statement was prepared. A total of 30 articles were critically evaluated, and the evidence thus gathered was used in the preparation of these recommendations. While preparing the recommendations, it was seen that there was a wide variation in different studies. So the grade framework, high quality, I think all of you must be knowing it. So quality of evidence and strength of recommendation. According to that, the consensus statement was made regarding method of preparation, patient selection, volume and dose, mode of injection, the necessity for activation or not, the number of sessions, interval between sessions, amount to be injected, ideal platelet concentration in PRP for androgenetic alopecia. Now, according to the consensus statement, the manual double spin method is the preferred method of preparation of PRP for androgenetic alopecia. Blood is drawn via venipuncture and collected in sterile tubes containing anticoagulants. And among the anticoagulants, ACD was considered the best because it did not harm the platelets or produce an aggregation before injecting. Blood is centrifuged using low RPM or a soft spin. The RBCs are seen to sediment on the bottom. The supernatant plasma is transferred using a sterile pipette or a syringe to another sterile tube without anticoagulant. The second tube is centrifuged at a higher RPM or a hard spin, and this spin leads to sedimentation of all cells, which are predominantly platelets. The platelet pellet is seen at the bottom of the tube and the overlying platelet poor plasma or PPP. The upper 2/3 of PPP is removed and the platelet pellet is gently resuspended in the lower 1/3 of the plasma. This suspension is PRP. Now, the RPM differs according to the machines that we have. So there's another consensus article on method of preparation, which has again been published in Indian Dermatology Online Journal. It gives a very good overview of how to prepare and regarding the different machines and how do we calculate the RPMs. A minimum of 3 to 5 sessions of PRP are recommended for AGA with a gap of 1 month between 2 sessions. Now, the ideal interval between 2 sessions depends upon the duration of growth factor release of PRP and the speed of hair growth. Marks found that when platelets are externally activated, 95% of growth factors are released within 1 hour. But physiological activation of platelets, that is within the tissue, PRP continues to release the growth factors up to 10 days. Now, the interval of either 2 weeks or 1 month may be chosen because growth factors, that aliquot that we give, last for 10 days. But however, there is a slow speed of hair growth that is 0.3 mm per day, so prudent to give monthly treatments. Patients with grade 2 to 4 Norwood-Hamilton classification of AGA are ideal subset for PRP. Betsy et al. Observed more inadequate response with 6 and 7, and those who had onset of alopecia less than 2 years. Jikini et al. Observed better results with stage 2 and 3. These are the cases. A total of 5 to 7 ml of PRP and 0.05 to 0.1 ml per centimeter square is the recommended dose of PRP for androgenetic alopecia. Assuming that the average area of the bowel scalp to be 150 centimeters square, the volume of PRP required may be around 7.5 ml. That is volume of PRP injected per site, 0.05 into 150. A smaller volume for a smaller area. And the distance between the injection sites has been uniformly used as 1 centimeter apart among all the studies. Now, smartphone apps are available, like an image meter, with which we can, calculate the area of the scalp. A recommended mode of injection of PRP in the scalp for androgenetic alopecia is with an insulin syringe or a small bore tuberculin syringes, and the depth is 1.5 to 2.5 mm. Now, there is a controversy regarding delivery of PRP via microneedling. Durat et al. She chose 1 into 1 centimeter area of skin and performed a derma roller treatment. It was 1.5 millimeter derma roller. They rolled 20 times and then massaged a dye over the skin. The maximum dye penetration was only 0.5 millimeter, despite the follicular dilatation by the roller. The dye could not pass below the level of the infundibulum. That is, it could not reach the site of action. So Sasaki et al. Has also shown that the depth of the microneedle penetration is reliable and reproducible only up to 1 mm. So mean depth of penetration was 0.92 for 1 mm needle and 1.1 for 2.5 mm microneedle. Fluorescent labeled platelets were able to penetrate slightly deeper, that is 0.95 mm versus 0.7 mm when using 1 mm microneedles. PDGF acts at bulge level, that is approximately 2 mm deep, and at the hair root, which is approximately 4 to 5 mm deep. So it's not advisable to perform topical PRP treatment using microneedling. Wastes a lot of PRP that is spread on the scalp and does not reliably deposit the platelets below 1 mm depth. So it is recommended to inject PRP with the help of insulin or tuberculin syringes where the depth can be easily controlled. Now, using mesogun also, we should use the point-by-point mode should be used instead of the Napas method to reduce wastage of the precious PRP that has been prepared. Now, activation of PRP is not required when it is used for AGA because in soft tissue, there is collagen, and collagen type 1 is a natural activator. So there will be sustained release once the platelets are inside the site of action. Gentile et al. Compared the results of activated and non-activated PRP and showed that there was more significant increase in hair count and hair density with non-activated PRP than with activated PRP. And the causes for this difference may be the slow activation of PRP by in vivo collagen type 1. So there is prolonged release of growth factors, endogenous activation of PRP, production of thromboxane A2, which activates additional platelets and amplifies the platelet aggregation and release of growth factors. External activation of platelets cause 95% of growth factors released within 1 hour, and physiological activation, there is growth factor release up to 10 days. 1 to 1.5 million platelets per microliter of platelets in PRP is recommended. Rugetti et al. Found a proliferation of human cultured umbilical vein endothelial cells that peaked at 1.5 million per microliter of platelet concentration. Zio et al. In his study, PRP on cultured human hair dermal papillae cells and found 1.3 million per microliter platelets in PRP to be the ideal concentration for dermal papillae cell proliferation. This was again confirmed by a study by Wong et al. And Jekini et al. Also got a positive response to PRP in androgenetic alopecia at a concentration of 1.1 million per microliter. And in all the studies, a higher concentration of platelets in PRP was found to be inhibitory. So these are the treatment before and after. Before and after around 4 sessions, and serial photographs of androgenetic alopecia after 6 sessions of treatment. So to conclude, PRP is a boon, I think, but correct patient selection is important. Good counseling to the patient, because many patients think that with one session of PRP, wonders can happen. So we need to make them understand that it works only after 3 sessions. However, in 6 weeks, there will be a decrease in hair fall. Then combination therapy, studies with combination therapies needs to come out. More studies are required for evidence as monotherapy, and we need to pool our data. Then standardized protocols are required to compare and validate the results. Thank you for the patient listening.
Thank you, ma'am. We shall now have a short question and comment session. So I call upon Dr. Sonia ma'am to lead us through this.
Thank you so much. That was a very excellent presentation by both the speakers. So I think all of the questions may be answered by them through the presentations, because the ones that I've been telling in the beginning, they were answering it one by one in their presentations. So let us see what is there in the chat box. If at all anybody has questions, please put it there. So one question by Rakhi J. What are the sizes or number of needles using Dermapen in microneedling for scalp and face? I think Dr. Rakhi, can you take this question?
Yeah. What was the question, Sonia, again?
What are the sizes or number of needles using Dermapen in microneedling for scalp and face? Size or number of needles? They're just asking about the density of the thing.
Actually, it depends upon the Dermapen that you're using. So it comes as standard for different pens. The one which I use is the Dermapen 4. So in that, we have got the set size. The needles are around 40 are there packed together. Again, it depends upon the different companies. It's mainly the depth, I think, So for the scalp, I use 2.5 and face maybe 1.5. Again, there's a controversy in Dermapen as well as microneedling combination, just like I told in my...
Yeah, you have already mentioned in the presentation about the depths and the different depths in that. Dr. David, do you have anything to add on that?
There are a lot of needles available, which is usually 12 needles in the Dermapen. So that is what I use commonly in my practice. But I don't use Dermapen that often. I usually inject. So that's the difference.
Okay, so then we'll go to the next question. Is somebody using PRP in ulcers? How can PRP be used in ulcers?
I think I can take that. Usually we inject around the ulcer. So clean the ulcer, dermabrate the ulcer, you inject around and inside the ulcer. But usually what I do is I inject around and pour the PRP into the ulcer floor. So, and give a dressing. That is what I usually do.
Do you prepare PRP gel?
Which one? PRF?
Yeah, gel.
I use both PRF and PRP. So, but for ulcer, I have used PRP, not PRF.
Okay. Okay, fine. That's it. Dr. Aki, do you have anything to add?
Yeah, I have used the gel. That is, you in the tubes, we'll not add an anticoagulant and then centrifuge it. And then we get a gel. So that gel is taken and then a dressing is put for the smaller ulcers. And for the larger ulcers, I usually inject around and into the...
Yeah, you can use the calcium gluconate for those stimulations so that the gel formation is there. The next question Isn't microneedling a mode of platelet activation by stimulating thrombin production through microbleeds? Yes, of course. That's what we've been talking about, because PRP, if you directly inject, it is always better if there is some more injury around that, because the injury itself is going to produce a lot of your own growth factors. So especially in case of scars, acne scars or other scars, that is going to be acting better. That's a good thing. Do we do fractional CO2 before or after PRP? That's from
Usually
Dr.
before.
Sridhar.
Yeah, before. Basically before, and then you can apply topical PRP. So it can enter through the channel. Can do the
Okay.
other way also if you are giving intradermal.
If you're giving intradermal, right?
Yeah.
Okay. Anything Dr. Rakesh could add, or?
Same.
Yeah, okay.
Then
This,
put in a-
I think in my practice, I do in two different ways. One thing, if I see that fractional CO2, I mean, the scars are a little bit difficult to treat, so I do 2 sessions of PRP as a different thing before the session of fractional laser alone. And then either if we want to do it along with that, it's only the topical PRP after the fractional CO2. If you are going to do it intradermal injection, don't do it before you do the fractional CO2, because once you do the intradermal injections, the whole area is going to swell, and the fractional CO2 is going to be very, really bad into that, because it may cause real ulceration onto the skin. So either do the thing on top of it, or do the fractional CO2 and then do the intradermal, as Dr. David rightly said.
Actually, you can, when you're giving topical, you can put an occlusive dressing after that. That enhances the penetration. You can put a cling film and ask the patient to wait for another half an hour. So that can increase the penetration of the, and secondly, if you are giving intradermal, you give into the scars, so into the depth of the scar for a better result.
Okay, good. That is from Dr. Dhanya. Excellent presentation, ma'am. Role of GFC. Yeah, that was something which I was about to ask about the experience of growth factor concentrates by the speakers. Dr. David, you would like to take it?
I have used only in 2-3 patients. So 3 patients I have used. I didn't see much difference, but I have heard a lot of good reviews about GFC concentrate. I didn't see much difference with PR. I compared it with PR, so I didn't see much improvement there.
Okay. Anything to add, Dr. Aki?
Yeah, we've started using it, but I think it's a little more time consuming than PRP. But I think from the reviews, the results are better. But when you search the literature, there is no.
Yeah, true. There are no literatures.
Yeah. There's no solid evidence to suggest.
Yeah, because there are lack of literatures, because this is relatively a newer technique. So right now in our practice, we've been using mostly GFCs now, because we were actually trying to see whether it is better than the PRPs, because we've been using PRPs quite some time. So we shifted the PRP to GFC nowadays. But what I think is, as Raki rightly said, there is it's a little bit more time consuming, because the separation itself will take half an hour first, and then only we can inject. So the patient should wait there before almost 45 minutes before we can inject. That is one thing. But the result wise, what I feel is it is giving much more better results than PRP, more faster result, which I wouldn't say better result, but most faster results. Because I've been comparing patients with after 3 sessions of GFC and after 3 sessions of PRP, I'm much more positive about that. So let's see what are the peer groups telling, and what are the evidences coming up in that. So definitely, I would vote for GFC in this time. Should we expect an increase in the hair fall post PRP?
Usually the beneficial effect is decrease hair fall in a short time. That's what you usually expect.
A few studies which I came across, in those studies, among few patients, they saw an increased hair fall. And
Okay.
in my practice also, I think 2 patients came back saying that there was an increased hair fall, but that was in a very short period they came back. So they continued the treatment and they had better results, but even studies. So I went through the studies to see if there was such a problem. So few patients, maybe, I don't know why, but I suppose if there is
Yeah,
a
true.
concentration of platelets, there is an inhibitory effect. So it could be the method of preparation or something. Because studies
Yeah,
also,
so-
there are few patients who have reported of an increase in fall after PRP.
True, maybe it's some contamination with leukocytes or something has happened before, but it's not a rule, but you can get. It's not a rule that it should get, but you can get.
Very few
True.
patients in very few
Yeah.
studies have reported.
Okay, so Dr. Rakhi, this is for you. From Dr. Kriti Ulal. Dr. Rakhi, you mentioned about PDO threads along with PRP. Does it matter which is the first, like thread or PRP? I'm assuming it's in the same session as well.
Yeah, it's the same session. And according to studies, you can basically, I have not done, but according to studies and according to my friends who are doing it, it is being done in the same session. And they usually inject before the thread is used. But I went through a lot of studies. You can do either way. So,
Okay. So, okay, that's it. The next question is from Dr. Rakhi again. From Dr. Rakhi, how is PRP preparation for face and hair different?
I think
Dr.
we
David?
prepare it the same way.
Yeah, it's what they recommended is PPRP for the rejuvenation and LPRP for the scars.
Scars.
Sorry, for the hair and ulcers. So slightly different, but I think it works for both. But they recommended PPRP for rejuvenation.
Okay,
But most of
it's
the
more
kits
or
are
less
LPRP.
It's
LPRP. LPRP. So I think more or less it's the same for both. But when you do the growth factor concentrates, the GFC kits they have
They
come
have a
with
different kit. Yeah.
they have more of a TGF beta more in the facial kit than the other one. So, but basically I think both are the same in not much different. We'll take 2 more questions for want of time. How can PRP cause blindness in perioral rejuvenation? It's an intradermal procedure.
It may be because you are going little deep. So instead of injecting intradermal, the skin and the periorbital area is very thin. So intravenous or intra-arterial injection might have occurred in that. So this can happen.
Just like the fillers causing the blindness, it might have traveled retrograde as a bolus. Okay. Does anticoagulant used in PRP has a role in pain while injecting PRP? That will be the last question.
Yeah, because of the
anyone can take it.
Yes, actually, without anticoagulant, preparations are less painful when you are injecting. Anticoagulants actually increase the pain.
Is there a difference between the EDTA and the ACD in terms of pain?
I am not very sure, but ACD is what is preferred, right?
ACD is more preferred.
Studies have shown that EDTA, the pain may be less, but the problem is EDTA will cause rupture of the platelets. They damage the platelets. So the whole purpose of PRP is, gone.
Yeah, there are a lot of controversies in this age. There are a lot of people for EDTA and for ACD. So it's a controversial thing. So it's while injecting PRP, yes. One more question, last question from my side, about the topical anesthesia or the intralesional, the local anesthesia. Does it affect the result of a does it affect the PRP outcome?
Should not sure, but the recommendation is you can use either.
Yeah.
Now the recommendation is you can use either, but I know I'm not very sure.
Okay, nowadays I think usage of 30 gauge needles are the kind of painless, so we go mostly with without any anesthesia, just with those vibrators to distract them. But studies have sometimes shown that the platelet aggregation was interfered with the local injectables. So better go for topicals, or if you want, you can just go without that. Okay, so
there is a lot of controversy around that actually. There are a lot of studies saying against and for. So
Okay.
now the recommendation is you can use
Anything. Okay. So with that, I think we'll come to the end of the session. It was an excellent session. All the two speakers have given us a lot of insight about the evidences, and I think everybody will be now ready to inject from tomorrow. So thank you so much. Thanks a lot.
Thank
Thank
you.
you.
Thank you.
Thank you, ma'am. Thank you, sir, for the highly informative and insightful session. Now we move on to the next session on non-surgical facial rejuvenation. I welcome Dr. Naveen Thomas, Consultant Dermatologist, Medical Trust Hospital, Kochi. Over to you, sir.
Dr. Naveen, have you started?
I'm so sorry. I think my this thing was on mute. Am I audible now?
Yes,
Yeah,
sir.
yeah, you can start from now. Sure.
Sorry. So I'll be talking on non-surgical facial rejuvenation. So if you look at the statistics, which is reported by American Society of Plastic Surgeons, there were 15.9 million minimally invasive cosmetic procedures that were performed in the year 2018. That is actually a 2% increase from 2017. And if you compare it to year 2000, it is actually a 228% increase in the number of minimally invasive cosmetic procedures. And the same trend actually doesn't follow for invasive or surgical cosmetic procedures. And if you look at the stats, there's actually a 5% decrease in the number of procedures as compared to year 2000 in year 2018. So that means our patients want more and more of non-surgical procedures which are minimally invasive, which give them possibly equally good results when it comes to facial rejuvenation. And if you look at the numbers, for specific procedures, the ones with the maximum increase are those for botulinum injections, chemical peel, laser hair removal, and procedures like laser skin resurfacing. And procedures like microdermabrasion, which were used quite a lot earlier, there's actually an increase in the percentage of procedures preferred by the patient. Now, aging, as we all know, is a progressive loss of skin integrity. Not just the structural stability, even the physiological function of the skin is affected. So there can be intrinsic agent which is genetically determined, and there's buildup of reactive oxygen species as a byproduct of cellular metabolism. And there are factors like UV light, pollution, cigarette smoking, etc., which adds on. If you compare the younger skin with the aged skin, there is reduce in the keratinocyte There's reduction in the keratinocyte size. There's reduction in the proliferation. There's reduced sebum production. There's reduced water content in the stratum corneum. Your dermoepidermal junction become flatter. There's reduced dermal thickness owing to reduced vascularity as well as reduced cellularity. And then there's reduced collagen turnover and decreased production of glycosaminoglycans as well as your hyaluronic acid by the fibroblast. So the proliferation and the turnover in a younger skin is much better, but as we become old, everything becomes less and the skin ages faster. Now, there are various modalities which we can use to reverse this. So I'll be talking mostly about these modalities. First, the topical creams which we can use. There are a lot of medifacial devices which are coming up. Chemical peels which we were using since long. Lasers for skin rejuvenation. And something which is on the rise now is use of radio frequency and ultrasound in skin tightening. Use of cryolipolysis or injections to reduce the fat content. And of course, Botox fillers and threads, which are the main non-surgical facial rejuvenation. Now, coming to routine topical therapy, we dermatologists are always good at prescribing topical medicine. That's what we used to do. But now suddenly we see the Instagrammers, there are this YouTubers, bloggers, who probably knows much more than what we know. And there are a lot of terms which are coming up every day, which often confuses us. And so we need to know what to give our patients. And this is as important as procedures because this is what they're going to use as a maintenance. And this is something which they can use without coming to you for every time for their problems. So choose your squad carefully. There are a lot of products which are available there. We all agree that sunscreen is a must when it comes to any facial rejuvenation. So that is your first product you start using. Usually I give a cleanser and a face wash, a non-comedogenic moisturizer, and depending on the skin type, vitamin C and retinol. This is more or less what I would want to put most of my patients on. And then again, depending on each patient, you can add on serums for pigmentation. You can add on, if the patient is confident enough to use a home-based peel, you can add exfoliations every week or every fortnight, depending on how the patient tolerates it. Now, medifacials is something which is again increasingly preferred by the patients. So in this procedure, there is a combination of mechanical exfoliation along with suction-based extraction, and an active ingredient is infused with the use of a pressure. So these are your equipments like hydrofacial, diamond glow, silk peel. These are procedures which can easily be done by your technician, doesn't require much of your involvement, and are preferred by patients who doesn't want to go for something which is invasive or serious. They just want to come get the procedure done and go, and they're happy with the mild result it gives. And there are studies which shows improvement with the use of hydrodermabrasion as compared to using the same product topically. So in this study, there was increased epidermal thickness, there was increased papillary thickness, as well as replacement of the elastotic dermal tissue, collagen hyalinization, reduction in the fine lines, pore size, hyperpigmentation, all of which were noted with the use of hydrodermabrasion as compared to topical application of the same polyphenolic antioxidant serum. Now, coming to chemical peels. So chemical peels is something which we all know. The use of chemical peels dates way back to the Egyptian era. We all know the famous milk bath by Cleopatra. We all know now the milk contains lactic acid, and it is one of the most commonly used peels nowadays actually. So chemical peeling is basically just a controlled chemical exfoliation of the skin. There is regeneration and remodeling of the epidermis and dermis, which results in the improved appearance of the skin. There are various indications it is used for. It can be used for photo aging. It can be used to give a glow, like a party peel. We can use it just before having any function. You can use deeper peels for your wrinkles. It can be used for both for mild as well as deep static wrinkles, and can be used for various conditions which causes pigmentation or post-acne, PIH, and things like that. Now, the classic classification of the peels is based on the depth to which it causes exfoliation. Your very superficial peels go and cause exfoliation of your stratum corneum. Superficial one extends to the papillary dermis, medium one to upper reticular dermis, and your deep peels extend up to mid reticular dermis. So depending on the percentage of the compound that is used and depending on the number of coats, your strength of the peel can increase. The mono peels that are used very commonly earlier, like glycolic acid, salicylic acid, and TCA peels that are used. The most common combination peel used earlier was probably Justnus peel. Now there are a lot of newer peels which comes up. There's increased use of mandelic acid, lactic acid, ferulic acid, and combination peels like salicylic mandelic acid peels or black peel, which is acetic acid based peel for inflammatory acne, that are being more used nowadays. Now, there are different ways in which we can use a peel. One is your sequential peel, where you use one peel which is followed by another peel. So you can either neutralize the first peel, or there are times when we add on the second peel without neutralizing. One example would be in a patient with acne as well as post-inflammatory hypopigmentation. We use a salicylic acid peel first for the acne, followed by TCA peel for the pigmentation in the same sit. Then there are segmental peels in which where different segments of the face, depending on the indication needed, we can use different peels at the same sitting. For example, if a patient is having an oily T-zone and relatively drier lateral cheeks, you can use a alcohol-based SA peel, which is a little bit more stronger on the T-zone area, and you can use a gel-based salicylic acid on the cheeks, which will be a little bit more milder. Then switch peels, this is something which we very commonly use. We use one peel initially when you start, and in the subsequent sittings we change a different peel. Like we can use a SA peel for first sitting in case of acne patient, and once the patient's acne has subsided and has only PIH, we can use a TCA peel or TCA phenol peel in the second, third, or subsequent sittings. And there is something known as punctuate peel. This is used for superficial wrinkles, where with the use of a cocktail stick, 88% phenol peel is applied on the along the wrinkles, which can cause frosting, PIH, but the wrinkles improve. I'm not very sure how good our Indian patient would tolerate a peel like that, owing to our skin type. Now, other areas where peels are commonly used, one increasingly now is the periocular area. Here the skin is sensitive. So probably it's better to start with a milder peel like lactic acid peel or 20% glycolic acid peel. However, I do in many of my patients go a little bit stronger subsequently in the fourth or fifth sitting, use a TCA plus phenol combination, because that can give better results. But that is only if the patient is tolerating your peels well in the first few settings. Again, lip peel is something which patients comes to us very often nowadays for. Lip pigmentation is something which many patients are worried about. Again, you can start with a milder peel here and increase the strength of the peel. Complications are not very common as such if you choose the right peel for the right place. Okay, there can be mild irritation, skin can be sensitive for some time. The moderate and severe complications which are mentioned here are hardly seen by us in our regular practice. Just showing a few results of the peel with phenol and TCA combination. This is one of the peels which I use very often. So it comes in different strength, and depending on the how patients tolerate, we can increase the strength. And for all the beginners there, most of the times, in the beginning stage of your career, you may not have a lot of money to invest on expensive equipments. Peel is something very good thing. Your cosmetic practice can begin with peels, which if used correctly can give you excellent results. You can see the before after pictures here after 4 sessions of phenol TCA peel. This is another patient who had mild acne and was very worried by it, and you can see the difference after 5 to 6 sittings of peels in these patients. Now, coming to next modality, we dermatologists used very often for facial rejuvenation, that is the lasers. So lasers which are used for skin rejuvenation, we can divide it into ablative lasers, like your CO2 laser, erbium lasers, non-ablative lasers like your Nd:YAG lasers or your erbium glass lasers, or fractional lasers. Fractional lasers can be both ablative and non-ablative. So your ablative lasers basically, with the damage, they cause evaporation and damage of the epidermis. That is very superficial. Your non-ablative may go a little bit deeper, Your fractional lasers have the advantage that it goes in columns, it can go deeper, and because the columns in between the area where the laser is passed is normal, there is a faster healing and the downtime is quite less. So this is again the classification of the lasers. Like I mentioned before, there's your carbon dioxide laser and erbium YAG, which are the ablative lasers. Non-ablative lasers, Nd:YAG lasers, diode lasers, erbium glass lasers, and your fractional lasers can be both ablative and non-ablative. And then there are your photobiomodulators, where without causing any thermal reaction because of the physical or photochemical reactions, you get a facial rejuvenation. Those are your LED lights, etc., which you use. Laser toning is probably something which is becoming very popular now. This is one of the uses of your Q-Sys Nd:YAG laser, where you use the laser in a lower fluence. So you use a spot size of about 7 to 9 mm or sometimes even 10 mm, and you use the fluence in between 1.2 to 2 joules per centimeter square. This can be done every week, every fortnightly, or every month, depending on the energy which you use and depending on how your patient tolerate. These procedures are usually safe. The endpoint is usually a slight erythema. The basic idea is to stimulate the collagen by heating it. Carbon peel, also known as Hollywood peel, which is probably becoming quite popular now. Even though when I search for literature, there are only very few reports of it, very few studies are there. However, it is in increasing demand among the patient. So basically, this procedure acts by reduction of the microbial colonization of Propionibacterium acnes. There is reduction in the sebaceous gland function and histologically proven thinning of the stratum corneum of the epidermis. I'll just show a quick video of the carbon peel. So this is the carbon peel applied first. You wait for about 15 to 20 minutes. You can use mode known as GN mode, which is there available in some lasers for the carbon particles to enter the skin. After that, you use your top hat mode, and you can take out these carbon particles that are there. So these procedures are usually done once in 2 weeks or so, sometimes once a month, and by about 3 or 4 sections can get a good results. Reduction in the oil content works good for pores as well as for acne. Just showing a few other results of Q-Sys Nd:YAG lasers. Even though we use it primarily for your tattoos, I think one of the very common indications where this is used is for your pigmentation. So this is just a patient of LPP, and you can see the changes with cyst settings of Q-Sys Nd:YAG. So I usually don't do lasers when the disease is active. I usually start them on medical management, and once I feel there's no further progression, disease is in the it's in a quiet state, I start them on lasers and go about 6 sittings once a month. This is another patient with LPP. You can see the changes in just about 2 sittings in this patient. Now coming to other newer modalities which are being very popular now, one is your ultrasound used skin tightening. The other one is skin tightening using radio frequency. So HIFU, also known as high intensity focused ultrasound, was approved in by FDA in 2009 for use in brow lifting. So there is basically accumulation of high frequency ultrasound beams at specific tissue site without causing any damage to the epidermis or the adjacent tissue, which causes coagulation by generating instant microthermal lesions and induce cellular damage and volume reduction of the target areas. The advantage of HIFU as compared to your laser or even radio frequency is that it can go much deeper. So it can go up to your superficial muscular aponeurotic system. So the results are can be much better in HIFU as compared to your lasers or RF. But at the same time, your downtime as well as complications chance are maybe slightly higher. And it is used mostly for lower face and neck. So for the procedure, the face is divided into multiple areas like shown in the picture. Topical anesthesia is used. Some people prefer using nerve block. And the focal depth where how much we go can be visualized on the monitor. The treatment times varies usually between 30 to 60 minutes per region. There can be swelling, erythema, and transient bruising that can be seen, which are usually self-limiting, and complete results we can expect by usually by about 6 months. So this is just a video which I borrowed from my friend. I don't usually do this procedure. You can see how the equipment is being used, the different areas that are being marked, and how the energy is being given. And this is just a study showing the change. You can notice the reduction in the volume and the tightening that is happening in the neck area in this patient 2 months after a HIFU therapy. The results usually last for about 1 year, and we can undergo the second sitting after 1 year. Coming to radio frequency, this is again something which is used very commonly now for skin tightening. So radio frequency is basically a part of electromagnetic spectrum with the wavelength between 3 kilohertz and 300 megahertz. So the electric energy that is generated flows through the tissue, which generates heat and which results in the stimulation of the collagen. In 2002, it was approved for the smoothing of the periocular wrinkles, and in 2006, it was later approved for use of treating facial skin. Now, when we tell radio frequency, depending on the number of electrodes that we use, it can be divided into 4 types. So monopolar is where basically we just used one electrode which is inserted into the skin, and we place a grounding pad at a distance tight on the skin, and the energy is passed. So the advantage of monopolar is that you can go a little bit more deeper, usually about 20 to 25 millimeters, whereas unipolar, bipolar, and multipolar are more superficial. Unipolar is a single electrode which remits RF energy in multi-direction. Bipolar is when there are 2 electrodes and the energy is passed between these. Multipolar is where there is 3 or more electrodes. I'll just quickly show you a video of use of monopolar. So this is basically a thermi type device. Usually it's done after giving tumescent anesthesia on the jaw area and the neck. And they've used the cannula here, which comes with the device for giving the tumescent anesthesia. And there's 3 sites of entry. One is here on the side, one is at the center, and one is in this area. So you insert the RF probe at a level above your platysma muscle, and then using this camera, which actually calculates the temperature that is produced at the epidermis. So at the epidermis, when a temperature about 40 or 45 is achieved, there's an internal temperature of about 60 degrees or 65 degrees, which is usually the endpoint. Now, unipolar devices, like I said, an example for it would be Dermavan. These, I think, are more of equipments which patients can buy and use at home. I was just going online, I could see a lot of online sites which are selling this. Bipolar or multipolar devices are basically a little bit more safer compared to your monopolar, but the depth of penetration is less. And this is a multipolar device that is being used. These can be used every 2 to 4 weeks. Endpoint is usually erythema, usually very well tolerated by the patients. The results may not be as good as your monopolar one, but the side effects is less, and the ease of use is it's much easier to use compared to your monopolar devices. Now, coming to microneedling RF, this has been there for quite some time. So this here basically there is a needle which actually goes into the skin and then passes the RF energy directly into the dermis. So your epidermis is spared because there is no downtime as compared to your fractional CO2 laser. That is the main advantage. So these needles are insulated and go into the dermis and deliver the energy there. So this can be used for treatment of acne scars as well as for a skin rejuvenation or tightening. So this is one of the protocols which are followed, known as genius lift, where 3 passes are given at different depth for skin rejuvenation. I usually go a little bit more deeper for scars that are there. I go up to 3 mm, and for acne scars if the patient is tolerating the procedure well. This again is study showing the results of CO2 laser and comparing it with microneedling RF. They've actually found a bit of better response in patients with microneedling RF. However, the results were not statistically significant. The difference was not statistically significant. Cryolipolysis, again known as cool sculpting, is a method where controlled cooling is done. You can see in the picture a device like this is placed for about 45 minutes. And with the cooling, the fat tissue is damaged. It takes about 45 minutes to do the procedure. After the procedure, massage is done on that area to remove and reshape. And a volume reduction of about 20.3% that was stable by about 6 weeks is reported to be achieved with this procedure. Again, something which we commonly use now is injection lipolysis using deoxycholic acid. You can see on the picture, these are the injection sites which are marked, which has to be 1 centimeter apart. A volume of about 0.1 to 0.2 ml is usually injected, maximum of 50 points. You have to leave 1 centimeter gap from the your mandibular margin so that your marginal mandibular nerve is not damaged during the procedures. Now coming to Botox fillers and thread lift, I'm just going to run through this fast. These are probably the most common procedures used nowadays for facial rejuvenation. There are different brands which are available, and studies have shown that no statistical significant difference between these brands that are there. The effects usually last for about 6 months. These are various indications for which botulinum toxins are used. You use a smaller volume for your upper face. Upper face is usually relatively easier for us to do. You go superficial on your frontalis muscle and on the sides for your crow's-feet, whereas for your glabella you have to go a little bit more deeper. To do Botox on your middle face and lower face, you need a bit more of experience. Fillers, again, something which is being used. Usually now there's more and more use of hyaluronic acid fillers because it's enzymatically reversible in case of if there's any complication. The degree of cross-linking decides the viscosity and the indication. And now there's a tendency of more and more less viscous fillers that comes, which can even be used for things like acne scars. So these are the common indications for which we used to use fillers earlier for brow lifting, tear trough correction, your nasolabial folds, etc. Now we are used for even facial rejuvenation, correction of your acne scars, like I mentioned before. Thread lift, again, something which is been there for quite some time, still giving excellent results. This basically is a cosmetic procedure that utilizes a biocompatible implant, which is placed into the deeper layers of the face and realign the tissues by using force. So concluding my talk, there's a higher demand for non-surgical facial rejuvenation of late. People actually, they want less invasive procedures which give them good results, no downtime. Simple and easy to do procedures actually can give you good results. So if you are in the early stages of your practice, focus on these procedures, learn these procedures well. A good peel done in multiple sittings can give a good results to the patient. Patient counseling is important. Of course, if you have the equipments like your HIFU and your radio frequency machines, that can give good results. Many a times, like we discussed in the previous talk, and like how Dr. David said and how Dr. Raki and Dr. Sonia said, combination of different procedures are often needed. Many a times we combine PRP with microneedling, with CO2 lasers. We combine peels and lasers together. So it's always a combination of procedures that give you better results. And invest in your equipment smartly. Just because someone else in the other clinic bought a good machine doesn't mean you need to buy it. Use your machines which you have effectively. There's no one way of treating your skin. There are different equipments which can help you, and be wise in what you want. And you have to make sure you get a good return for the equipment which you invest in also. With this, I will conclude my talk. I want to thank IADVL Kerala and Dr. Vinita for giving me this opportunity and to be part of this wonderful scientific session. Thank you.
Thank you so much, sir. We come to the end of today's session, and I welcome Dr. Febin Ma'am, Joint Secretary, IADVL Kerala. Over to you, ma'am.
Morning, everyone. This was really an informative and engaging webinar on platelet-rich plasma as well as non-surgical facial rejuvenation. The presentations and discussions were truly insightful and provided valuable perspectives on the use of PRP and rejuvenation. I thank Dr. Faisal Sir, IADVL Kerala President, for inaugurating the session, and Dr. Anuradha, Honorable Secretary, IADVL Kerala, and EC for all their support and guidance. I would like to thank the esteemed faculty, Dr. Sonia Firoz, Dr. David Pudugadan, Dr. Jackie Nair, and Dr. Naveen Thomas for sharing your expertise and experience in the field of regenerative medicine. The efforts you put into sharing your knowledge with us is much appreciated. The IADVL Kerala online media cell, chaired by Dr. Vinita Varghese and convened by Dr. Joanne, has time and again come up with well-planned, high-quality content, which is beneficial for all the members, and I extend my heartfelt thanks. A program becomes meaningful with active participation of the delegates, and I thank one and all for taking the time out on a Sunday to attend this webinar. Wishing you all a good day. Thank you.
Thank you, ma'am. I once again thank everyone present here today with us. Have a great weekend. Thank you.
Thank you all.
Thank you.
Thank you.
Thank you all.
Thank you.
Thanks,
Thank
thanks
you.
everyone.
Thank you.
Okay.
Thank you.
Bye bye.
Enjoy.
Thank you, everyone. Thank you so much.
Yeah, bye.
Bye.
Bye-bye.